Turner syndrome is a chromosomal disorder that occurs exclusively in individuals assigned female at birth. Normally, females have 2 complete X chromosomes, 46XX. In Turner syndrome, one of these X chromosomes is either completely absent or structurally abnormal, most often resulting in a karyotype of 45X. The missing genetic material disrupts the dosage of genes that escape X inactivation, leading to the characteristic clinical features. Think of the genome as a library of instruction manuals. When one manual is missing pages, the body cannot follow certain instructions correctly, which manifests as the phenotype of Turner syndrome. The primary etiologic event is nondisjunction during meiosis, which results in an egg or sperm that lacks an entire X chromosome. When fertilization occurs, the resulting embryo has only one X chromosome, 45X. Less commonly, structural abnormalities such as deletions, isochromosomes, or ring chromosomes arise from parental balanced rearrangements that are passed on. These mechanisms are stochastic. They are not inherited in a classic Mendelian fashion, but a parent who carries a mosaic or rearranged X may increase the risk of having a child with Turner syndrome. Because the second X chromosome is absent or defective, genes that normally escape X inactivation, for example SHOX, TIMP1, and some pseudoautosomal region genes, are underexpressed. The SHOX gene, located in the PAR1 region, is crucial for bone growth. Its haploinsufficiency explains short stature and skeletal dysmorphisms. Likewise, insufficient expression of genes involved in cardiac development predisposes to bicuspid aortic valve and coarctation of the aorta. Ovarian dysgenesis stems from loss of dosage-sensitive genes necessary for germ cell survival, leading to streak gonads and primary ovarian failure. Turner syndrome affects roughly 1 in 2,000 to 2,500 live female births worldwide, making it one of the more common chromosomal aneuploidies after Down syndrome. The prevalence is consistent across ethnicities and geographic regions, indicating that the underlying meiotic errors are not population-specific. The condition is often underdiagnosed because milder phenotypes, for example mosaicism, may go unnoticed until later in life, especially if growth impairment is modest and cardiac or renal anomalies are absent. The classic phenotype includes short stature, often below the 3rd percentile, a characteristic webbed neck, pterygium colli, low posterior hairline, and a broad chest with widely spaced nipples. Gonadal dysgenesis leads to primary amenorrhea and lack of secondary sexual characteristics unless hormone therapy is initiated. Cardiovascular anomalies, most frequently bicuspid aortic valve and coarctation of the aorta, may present with murmurs or hypertension. Renal malformations, for example horseshoe kidney, occur in 30 to 40% of patients, and lymphatic abnormalities can cause swollen hands and feet, lymphedema, in infancy. Diagnosis begins with a thorough physical exam noting dysmorphic features, followed by a karyotype analysis from peripheral blood lymphocytes. The laboratory process involves culturing cells, arresting them in metaphase, staining, for example G-banding, and visualizing the chromosomes under a microscope to count and assess structural integrity. A result of 45X confirms classic Turner syndrome, while 45X/46XX or other mosaic patterns are reported when multiple cell lines are observed. In prenatal settings, non-invasive prenatal testing, NIPT, can flag sex chromosome aneuploidies, prompting confirmatory invasive testing, amniocentesis or chorionic villus sampling, with karyotyping or chromosomal microarray. The majority, approximately 50 to 60%, of individuals have a uniform 45X karyotype. The remainder exhibit mosaicism, 45,X/46,XX, 45,X/46,XY, etc., or structural X chromosome alterations such as isochromosome XQ, ring X, or deletions of the short arm. Mosaicism generally correlates with a milder phenotype. For instance, patients may achieve spontaneous menarche or experience less severe cardiovascular disease. Conversely, structural abnormalities that retain more SHOX copies can ameliorate short stature, but might increase risk for other organ system defects, depending on the genes involved. Management is multidisciplinary. Recombinant human growth hormone therapy, initiated ideally before 5 years of age, can increase adult height by 5 to 10 centimeters. Low-dose oxandrolone may be added in late childhood to augment growth velocity. Estrogen replacement, started around 12 to 13 years, induces secondary sexual development, supports bone mineralization, and protects cardiovascular health. Regular cardiac imaging, echocardiography, MRI, monitors aortic dimensions and valve function. Renal ultrasound screens for structural anomalies. Bone health is overseen with DEXA scans. Calcium and vitamin D supplementation are advised. Psychosocial support, speech therapy for possible language delays, and educational accommodations are also integral. Turner syndrome arises from random errors in meiotic chromosome segregation. There is no known preventive measure before conception. Genetic counseling can inform families about the low recurrence risk and discuss prenatal screening options such as cell-free DNA testing. While advanced maternal age modestly raises the risk of nondisjunction for any aneuploidy, it does not specifically increase Turner syndrome incidence. Early postnatal or prenatal detection permits timely initiation of therapy, which improves outcomes. With contemporary care, life expectancy for Turner syndrome patients approaches that of the general female population, albeit with a modest reduction due to cardiovascular complications. Early detection and surgical correction of aortic coarctation, vigilant blood pressure control, and routine cardiac surveillance markedly lower mortality risk. Osteoporosis prevalence is reduced by timely estrogen therapy and bone health monitoring. Fertility remains a challenge, however. Assisted reproductive technologies, egg donation with IVF, enable many women to achieve pregnancy, though they require obstetric care in a high-risk setting. Current research explores adjunctive therapies to optimize adult height, such as combining low-dose RHGH with oxandrolone, which has shown additive effects without substantial virilization. Gene editing platforms, CRISPR-Cas9, are being investigated in vitro to restore SHOX gene dosage, though clinical translation remains years away. Longitudinal studies demonstrate that initiating low-dose estrogen before the typical puberty window improves bone mineral density, mood, and cardiovascular risk profiles. Additionally, novel imaging biomarkers, four-dimensional flow MRI, are under evaluation to predict aortic dilatation progression, allowing preemptive surgical planning.